Good morning to everybody. Glad to be here. And I want to start talking about the title of my presentation. Because this is the official title, the one that you can read now, but I should say that the right title can be Implant Stability and Primary Retention, Still a Personal Evaluation. Once upon a time, I was younger. Difficult to believe, but it is. And I was younger, and this is 1996, when I was in Los Angeles, attending a master about implantology, and the boss of that master was and still is Sasha Jovanovic. And during my course there, I was so happy and pleased to go to the private practice of Professor Peter Moy. So actually, I'm so glad to be here today to speak together with Peter. And at that time, attending this private course, Peter did a very great job, a big restoration of the jaw, placing some implants. And because Peter was Peter already at that time, so glad to be there, well, he did a very, very difficult treatment. And all the present at that moment, we were doubting about the true stability of the implant that Peter placed at that. And at that time, the only way to believe on the stability of the implant was based on Peter Moy experience. If we do that today, we don't have any more to rely totally on that. Because we are in an EO meeting now, and we can't mention Frank Renoir, that is one of the founders of the EAO. And Frank Renoir wrote a lovely book that you can see here, together with a pilot. And on this book, they explain to us that one of the main risk factors is the human factor. So the point, the question, the issue is, when we do have failures, the failures comes out from our failure more than from material failures. And I'm sad to say, because I'm Italian, that this is one of the most famous demonstrations about the fact that mainly the problem is because of the human factor. May I ask to the technician to let's start the timer, if you don't mind? Thank you. So what we will talk about today, trying to keep the time, is try to redefine the implant predictability concept. The meaning of the torque concept. Too often we have misleading information from torque values. And to understand what we do when we treat patients placing implants. Today we are facing a totally different kind of patient than times ago. Today we have more demanding patients. Today we have more difficult patients to be treated. And we have also a huge expectation from people that come to us, also because of the media requests. So we are talking about one stage, early loading, immediate implant positioning. So many, many new issues today. And this is what we expect to have today. And this is one of the main problems, because we rely so much in new procedures, like this one, that is a guided procedure. And today we have a sort of religious belief about this procedure. And let me tell you, that is a big, big mistake. because some days we have some wrong information from the radiologist's point of view. So if we do rely on our images totally, we can have problem. What about this? Do you think that this is a well-placed implant? The patient feels pain and goes back to the dentist asking for a solution of her pain. And the dentist says the OPG and the periapical is perfect, it's fine, so why are you complaining about? But the problem is that many times X-rays give us misleading information. So this is what it was. So we need to be very careful about that. And we need to understand that the actual procedure are not always so reliable because, as you can read here, if you are confident on the data that X-rays give us, we can make some mistakes. Also because maybe the images that CT scan is taken from a wrong inclination angle. That comes out with some variation about the angular situation and the linear situation. And if you do have this in a dental surgery, it's a mess. Maybe talking about 1.1 or 1.2 millimeters in an orthopedic treatment, it's not that big problem. But what about us? Many times, for us, 1 or 2 millimeters is the difference between right and wrong. So we cannot totally believe in what the new procedures, the new system gives to us. It's one more option, is an additional solution, but is not the final solution. Because if you do flapless procedure, and this is the final result, there is no excuse. There is no reason to say, well, but at least I did a flapless procedure. Why? Tons of papers says that there is no reason to avoid a flap in terms of comfort for the patient. And if to do and to make a flap gives to us and to the patient a more predictable final result, please do that. And what's the meaning of primary stability? It's a quite old concept. And Neil Meredith, 1990s, was one of the first person in the world starting to talk about the concept of frequency resonance. And Neil Meredith has been the inventor of this concept. And Neil, here you can recognize Neil with me during a very important scientific meeting, as you can see. We were talking several times about the importance of the primary stability. So let me go through this easy concept, but not that common to be understood. Micro-movement is the issue. We have to try to avoid micro-movement when we do our treatment. And we need to have a good, the best primary stability of our implant. But primary stability is not measured by the torque. When we put the implant, the torque gives us a dimension of a measure of the torsion, let me say, of the implant. But that's not the main issue. What we need to understand is the importance of the lateral micro-movement. And this is what we can measure with the frequency of resonance. So there is a lack of correlation between ESQ and torque. And we have to understand that torque is not a linear correlation with the ISQ. And what we need to understand as well is that the micro-movement can be possible. It's not something that we have to avoid totally, but we have to control it. So, if the implant have not a good primary stability, if we have axial movement, the risk is to lose the implant. And that is the meaning of the healing period we had following the Brandenmark concept from times ago. So the reason why we were used to wait for 3 months or 6 months was because of avoiding the micro movement and the axial movement. Nowadays, we move to a new concept that is not necessary to wait such a long time, but still what we have to get is a good implant stability. So what is primary stability? How we can define the primary stability? It's a mechanical friction between the bone and the implant. And we have a primary stability that is more mechanically at the beginning, and that will be a more biological stability in a second stage. And this switch, this passage between mechanical to biological stability happens after 3 weeks, almost. And this is what it happens. So at the time 0, I place my implant, and when I do my implant treatment, I expect to have 100% of implant stability because of a mechanical friction. So I'm starting from here. And of course, at that moment, at that 0 time, I have no biological stability. Through the time, the mechanical stability started to decrease, while the biological stability started to increase, trying and hoping to have, as a final result, a very high good stability. So what is important to understand from this slide is that after a certain period of time, between 2 to 3 weeks, we are losing the mechanical stability, not having already the biological stability. That is the most dangerous period, the most dangerous time during our implant healing. What about the torque? Torque is not correlated, as we usually think, with the implant stability, because torque is a combination between the friction given by the implant and the bone, but is linked with the quality of the implant, the surface of the implant, the quality of the bone. If we have more or less blood that is play like a lubrication system, and for the implant itself. So actually, changing the diameter of our implant, we have a totally different friction or torque. And this is one of the main issues. Companies are used to let us know what is the torque insertion number as a universal concept. But this is wrong, because the torque needs to be accorded to the dimension of the implant, for example. If I have a double dimension of the implant, the torque will tremendously increase. And that's why the torque is not really the final information, because it gives us a manual perception. I can be glad to have a high torque. That means I feel to have a huge stability of my implant, but this is a mechanical stability that is not linked with the biological stability that will become after 2 or 3 weeks. And that one will be the true reason of our success. So torque gives us the feeling that, great, I put my implant in a perfect way, but be aware of the mistakes. So the torque is that. It's not the only solution. And we have to keep in mind that it is much more important to consider the concept of BIC, bone implant contact. And because of that, we have to think about some new concepts, like this one. So cortical bone gives us a good primary retention, but if I'm trying to force too much my implant, I can damage the cortical bone. So I can have a good feeling, a good sensation of implant stability, but it doesn't mean that this implant is right, well positioned. So I'd like you to move from a carpenter approach to a more dental or surgical approach. We don't have to be confident only because we feel that we have a huge grip between, but that we are expecting a biological answer from our bone. And the frequency of resonance is a more predictable element, more predictable and more easy to repeat than torque or percussion test. It acts like a tuning fork, and we have a scale from 1 to 10. 10 is the higher, 1 means no retention at all. And it works putting a magnet over the implant. We have different magnets, smart peg, according to all the main implant products and companies. And then we can test the linear movement that your implant can have. And what is the advantage of this way of testing? The huge advantage is that you can repeat it during your surgery, during your prosthetic phase, so you can follow the healing processes of your implant. So it's easy to repeat. And if you compare with the torque is something that, given that it is a wrong information, but still is a wrong information that anyway you can get only during the implant phase, during the surgical phase. You can't repeat after that. Very quickly, if you want to put one implant, if you want to do a some modified technique, and you want to check if this implant have a good retention to be loaded immediately or not, this is the torque. Great. But what does it mean? It means that we perfectly impacted and that we reached the 35 Newton per centimeter, but you can't repeat this measure. And what I do prefer to have is a torque, ESQ evaluation that give me some values. And if I have 77 value from each side, it means that the primary retention is good enough to start with an immediate load. But what is the other advantage? Is that during my healing period, if something goes wrong, if I want to check it again, if I will see a reduction of this value, I can decide to remove the temporary restoration or to let the implant heal longer. So when we can take the measure of our implant at the implant placement time during the, let me say, baseline, and then we can check during all the period of the healing of this implant. And if you check between placement, abutment, and 1 year, you can see if you stay in a green side or in a red side, and because of that, we can decide if everything goes wrong or in a right way. And of course, just to give you an example, if your ISQ is lower than 55, you need to reconsider your treatment plan. So what is the message, the take-home message of that? Is that we have very easily the possibility to have something that helps us to have a more objective and less subjective data than before. So nowadays, we don't need to have the Peter Moy huge experience to feel that it works. That is great, but we can't buy his hands. So what we can buy is a smart peg. So to move from a personal feeling to a more predictable, objective feeling. And try to think about also the communication between you and your patient. When you treat your patient, you can say, okay, I feel that it's good. Because you see, this is a number here. So I will do my loading treatment. And if I have a wrong number, I should say, okay, I don't like to put my temporary restoration on this. And maybe the patient should say, okay, come on, you are not a good dentist. My sister went to another dentist and she had immediate loading, so you are not great enough. Okay, that's not my personal ability. This is a value. Your bone is not good enough. Or when you have a related patient from your colleague, what about the huge opportunity to give to your colleague a value? So you can tell to your colleague, listen, I put this implant, we had a 78 value of ISQ, so I think that is good. You can check after 6 months what is the value of the ISQ. And very quickly, let me end talking about the relation between micro movement and value. Is not a linear relation. So between 60 to 7, that means only 10 points, the difference in terms of micro mobility decreases around 50%. And well, not time enough to talk about the Young's modulus, but let me say very easily, if you put a normal screw inside a brick in the wall, the consistency of the brick is different from a wood. Do you follow me? So, Also, if you have a 100% bone implant contact, that means that you have a full coverage of your implant surface. But if the quality, the density of the material you are implanting is different, you will have a more or less micro movement. Is that clear enough? Also, if you glue your screw, if your screw is glued inside the bone, that means 110% of BIC. But if you have a D4 quality of bone, you still can have a micro movement. So we needed to keep all of this data together to better understand that if the young modulus is very high from the beginning, you cannot expect it to have a huge difference after the healing period. This is totally different if you start with a low density of the bone. And if you have a low density of the bone at the beginning, increasing the bone implant contact, you will have a better stability. But this is not so true if you start with a high bone density. So, ending with my presentation, let me summarize. This is not a recommendation, but is a way to understand that nowadays we have numbers that can allow us to understand when and if our implant is ready to be loaded, ready to be kept in place, or ready to be removed. So I let you know that if you see that the level, the value of ISQ started to decrease, then you have to reconsider your treatment plan. So, thank you all for your attention. Thank you, Ulla, for your kind invitation to be here. And I pass my microphone to Peter Moy.
Thank you, Professor Labanca.